TB, lung disease, stroke and HIV, computer-aided X-ray diagnosis, and point-of-care ultrasound in resource-limited settings. I'm very privileged to have been part of the cohorts of people who took part in her POCUS training here in Ghana. So ladies and gentlemen, please help me in welcoming Dr. Liz Joekes. Again, please engage your virtual hand claps and let's welcome her to take us through the first lecture for the day.
Good morning, Joa, and good morning, everybody. Thank you so much for a very generous introduction. It's really fantastic to be here. Apologies, but I'm not given permission to share my presentation. Yes, now I am allowed to share my presentation. So yes, am I also allowed to open my video now? Yes. Hello, good morning, everybody. Thanks again. It's really wonderful to be here and to see so many people interested in this topic. When I first went to Conference as apologies, I just need to get my screen share up. Where is it? This one, share. Here we go. That's a lot better. Sorry. Yeah, when I first arrived in Conference, I was welcomed by two medical officers without whom I could not have managed, given that I came straight from the Netherlands and had no prior experience of working in Africa. And for them, that was quite an unusual step to take because radiology was really not a big interest that people wanted to get involved in, and to see everybody here now is really wonderful. And thanks again, Adjoa. It was really lovely to have you on the program, and I've seen that you're already taking your skills and POCUS training further with further training, so that's really wonderful. And also I would like to say how happy I am to see that Prof. Agundoye is also a speaker in this program. Because we were on a podium together earlier in the year at the European Conference of Radiology, and it's really very excited that we're here together again today. So thanks for inviting me. So you've done all the introductions, so that's my background. That's made it a little easier for me, especially the fact that I'm really interested in health systems and sort of more the public health side of things. I'm looking at this topic of global standards and local solutions more from a sort of health system perspective. I do have some examples just of actual adaptations that you can make, but I've just taken it a little bit, I'm stepping a little bit, zooming out a bit and thinking about what this actually means. So I'll briefly touch on my background, but Adjoa has made it much easier and quicker, so that's great. What I will do is also look at what happened to radiology as a profession in that same time period between 2004 and 2024, because I'm now so old that I have a 20-year view on this, both personally and when it comes to radiology itself. I'll briefly touch on worldwide radiology, what we do, but I would refer to the website if you really wanted to learn more about it. Then I'll go into the topic of standards, which is what we're all here for to speak about. Developing local solutions. We'll come to that. I'll cover things to consider when you're thinking about local solutions. I'll give some clinical examples, some practical examples, and a few examples of how we're trying to do this through the work of worldwide radiology. And then future directions. So how did I end up in Conference in 2004? I trained in the Netherlands, so you can say that's right up here in this green zone. I trained in the late 80s and early 90s, and the Netherlands were at that time really, evidence-based medicine was really emerging there as a new way of thinking about how we do medicine. I was very much there at the time when the concept of standard operating procedures was introduced. That really wasn't a structured thing before that. Now we're all used to them, but at the time that was a new thing, and the Netherlands were quite sort of advanced in trying to develop that. They're always good at logistics, so I'm operationalizing things in a structured way. I grew up with that in my radiology training. My training was also very ultrasound heavy, because in the Netherlands, all ultrasound is done by radiologists. We have some vascular sonographers, but it's mostly done by radiologists. At the time, MRI was almost still experimental. CT was, beginning to become more widespread, but was still considered a luxury, expensive tool. So ultrasound was always our first go-to wherever possible. And I think that's relevant because I took that when I then came down to Ghana. And just so you know, I'm actually in Ghana right now. So I'm talking to you from on the continent. So I finished my radiology training. I decided to become an interventional radiologist. But before I did that, I had a holiday in Zambia. And I went to visit a friend who was working in a district hospital. And she said, while you're here, there's an ultrasound machine here in the corner that the Dutch government donated once upon a time, but nobody really knows what to do with it. And completely unplanned, I spent a great 4 weeks really trying to get her to get some basic useful skills to be able to introduce that as an extra diagnostic into her clinical practice. So that was sort of my first experience of training clinicians at the point of care. And then I could see how valuable that was for somebody who had no other diagnostic tools in that hospital. So that was my first personal experience of, the need and what could be achieved with diagnostics in Zambia. Went back, did my interventional training, but that experience stuck in the back of my mind. And then I decided to apply for a job and ended up through the World Health Organization diagnostics group in Komfo in Ghana. With that background and not having done any sort of, apart from in Zambia, prior learning about diseases and health systems in Africa, I had a very steep learning curve. And even now, retrospectively, you might think, well, what actually did I think that it was okay that I did that? But like I said, I had really great help. I was open to learn. And there was just a new CT scanner there. So I was able to bring my knowledge of radiology principles and try and start to, and that's where this is exactly the topic of today. How can we work with the tools we have and the principles we know to really bring out the best diagnostic opportunities for our patients? There's a hand up.
Dr. Liza, we'll take the questions afterwards. It's probably a mistake, so you can go ahead.
Okay, I thought maybe you couldn't hear me. Okay. So yes, so I spent 3 years there, and I really, really learned an awful lot about making the most of it, dealing with all the challenges that many of you will understand, waiting for suppliers to come and repair equipment, patients not having funds. I mean, I really had 3 years of in-depth exposure to that. I tried to do as much radiology teaching as I could. It was a great experience, and I've loved coming here ever since. These are some examples of the kind of things that was the majority of the work, x-rays with TB patients, lots of trauma, and again, an example of so many young men who come in with big swellings. And clinically, your first thought might be that this is probably a hepatoma, but with ultrasound, it turned out it was actually a massive hydronephrosis. And because I had trained in interventional radiology, we were then able to drain that for the patient. So briefly about worldwide radiology, basically what happened is that I started talking to my colleagues about these things, and they were like, oh, we'd love to be involved, rather than packing a bag and just going off somewhere like I did. Bringing people into well-structured and well-planned projects can be much more effective, because then somebody can come and do a specific task, or work with a partner on a research project, or to structure it more. And on the other side, more and more people through Liverpool were trying. I then went to Liverpool, as you mentioned. So in Liverpool, more and more people were saying, could you work on my project? Could you help me with my project? Like, woof. So basically, we started this to bring all the people together who are interested in this, but also to be able to start raising funds, to really focus on how can we collectively, across the world as colleagues in radiology, work towards improving access to medical imaging. So I'll refer to the website for blogs and further things if you wish to. If you wish to sign up to our newsletter, we have socials. Please do have a look. So that's my story. So meanwhile, what happened in Africa with radiology? So back to Zambia, where it was a similar machine. It wasn't this one, but where I found that machine, really between 1998 and the early, I would say the late 90s, there was, thanks to people like Prof. Agunloye, who has really, the few people on the continent who were doing radiology were really trying to build this specialty from scratch. That's a massive job, but to get a whole postgraduate program running. So there were a number of people working incredibly hard to make it happen. But by the time the 2020s came along, there was wider interest from, mostly driven by the oncology community, actually, to say, well, look, there's a lot of inequality in this area around the world. We look at this map. This is part of a big sort of assessment program that was done by the IAEA and the cancer community, and in their report, 2021 report, which I recommend you have a look at, you can see that if you look at the number of radiologists, that Africa was really, really suffering. And with that, it comes all the rest of that. There's nobody to bang on the doors and say, we need more services, we need more equipment. There were radiographers who are trying their best, but they have a less strong voice, maybe, in when political decisions need to be made. So this was really the situation almost 20 years later still. Meanwhile, the dark green areas on the map, the so-called global north, where I am from, radiology was absolutely going bananas. CT was booming, MRI booming. This is a picture of the European conference, only just the RSNA, the industry area, not even the conference, just industry. This has become a multi-billion-dollar industry, and we started using this mostly because of NCDs, non-communicable diseases. Up north, non-communicable diseases have been around way longer than now in Africa. So that has driven a lot of that imaging, plus defensive medicine, etc. But this maybe, I'm open for discussion, but I think what has now driven the interest in radiology and imaging in Africa is because I think NCDs and the cancer community, the issues of cancer are really also now affecting this continent. Infectious diseases have just less traction when it comes to policy, when it comes to funding, when it comes to what people really, the people who hold the money, who are all in that area in the north with all the those green countries, and then, Australia. Infectious diseases was never really a thing, or it's like, how much do you invest in that? And I think that also one of the things that plays a role is that we all have, cancer is seen as the emperor of all maladies. It's a terrible disease, and it really is very, it brings along a lot of emotion, and there's a very strong lobby in cancer. And this is a wonderful book if you're interested. It gives the history of cancer treatments, how patients have. It's a fantastic read about a very awful disease. But I think that has driven a lot of what is now happening with this interest. So, like I said, a lot more at the same time, there were more medics entering the radiology. I mean, there are now nearly 100 people on this call, all interested in the topic. That's fabulous. Globalization and international links, more people hearing about this, in the last 5-10 years. There's a growing middle class, and there is a growing market, and we have to be quite clear-eyed about this. Emerging markets, all the people who are selling their equipment are seeing opportunity. That is not, that's, that can drive innovation as well and change. when it comes to this provision side, diagnostic imaging is very often not part of a national health strategy, and that is now also changing. National health policymakers are realizing it was very much the poor cousin of medicine is the diagnostics, so also the labs. It's now beginning to change, that people realize we really need diagnostics. These scientific publications coming out, the Lancet Commission Group work, and like I say, the opportunities for $1 billion industry. So ultimately, and driven by a very sort of enthusiastic and pushing group of people, in May this year, the World Health Assembly adopted a resolution that supports the strengthening of medical imaging capacity around the world, not just in Africa, but around the world, where the gaps are. That's important because that means that unlocks major funding. It allows policymakers to, draw on funds to invest in imaging. It's a big document. I recommend you read it. And I think that's a major step forward to really build services. I would caution it's very much focused around potentially tertiary and higher levels of care. But as a community, we can think about how we also impact the lower levels of care. So then coming to standards, global standards. So I went away and thought, okay, I'm really interested in this topic. Always have been, because I'm always thinking about, how could we do this better? How can I do the best for the patient with the least of resources? But I thought probably reading the program, this is also thinking about standards of radiology practice. So if a patient comes in with a trauma, what is the standard of imaging that they should have to get their diagnosis? And it's, in my view, there are no global standards. There is no such thing. You don't do the same thing for the same patient situation everywhere in the world. It would be nice if it was the case, but that's not the reality. So actually, I think we have to be careful that we're not confusing standards from the United States, standards from Europe, standards from New Zealand and Australia, and interpret those as being the global standard. I think that is potentially a sort of hangover of this global North dominance, even you might want to call it colonial approach, that whatever comes from the North, where the standards are set, that is how it then should be done. Of course, I think, when you think of radiology service delivery, there are universal standards when it comes to things like radiation safety. If you use radiation, it has to be safe wherever you are on the planet. Whatever you choose to do, you have to make sure you do it well, that you do deliver quality, that you assure quality, and that you are held accountable as an individual and as a service. And whether that is doing a CT report or whether it is managing, overseeing ultra-portable X-ray rollout in a TB program, the accountability is universal. But what you're actually doing, which tool you choose to image with, that is not universal. That is actually very context dependent. I see radiology modalities as a box of tools, and I think, how can I apply that box of tools best to the problem patient population that I see, the resources that are available. So to me, it's not trauma equals CT scan. For me, it's trauma, where am I? What have I got in my toolbox? How much can I spend? Then we decide which test we can do. Who requests the scans, who approves who can be scanned, who interprets it, all context dependent. And then more broadly, that's related to radiology, but that sits in the wider system. We are part of the bigger picture. So which target populations are we thinking of? If we're a big trauma center in a capital city, and we see lots of, like in Cath, the number of trauma, it was terrible, it was really awful. But therefore, the CT scanner made good sense because, there was lots of trauma coming through, and there was an orthopedic surgeon and a neurosurgeon. So you could actually also treat the pathology that you were detecting. doing CT scans in a context where you haven't got the neurosurgeon who can then do something about the brain injury, then there's no point in doing that CT scan at all. So that's what I mean by where are you, which patient population? What does the patient even want themselves? You know, we have to think about what do patients want from our services, and what are the care pathways that are available to them. Like I say, there's no point scanning somebody's brain if there's no pathway to a neurosurgeon. Funding models, does the patient have to pay out of pocket, which is often the case. Are you in a communist society where funding is across the board, or are you in a very unequal society where there is a very wealthy group of people and underserved populations? Is there a commercial element to the services? Is there an academic interest? Do people want to scan because of research interest, personal interest? All these things play into this. Then there is the issue of acceptable uncertainty and litigation. And I think we have to think about this very hard, because radiology in wealthy countries has become incredibly susceptible to litigation. And that means that it influences how we make our decisions. If I have a diagnostic accuracy for a test that is 85% overall, I think that I'd be very hard pushed to say in the UK, well, I'm not going to do that CT to get to 98% accuracy. But if you're in a situation where you can get 85% accuracy and you can avoid spending a huge amount of money to get to that 98, the amount of money that might actually have a catastrophic impact on that patient's life, maybe that 85% is better than having no test at all. So again, thinking about, you know, how much uncertainty can you accept? And are you in a situation of litigation? And I think we need to push back on this litigation issue very hard, because it's taking so many resources as a community. And then there are the cultural, social, and individual beliefs. Like I said, a society might decide to look after all its people equally. A society might decide to be very libertarian, neo-capitalist, and say, you know, it's a free for all. If you've got the money, great. If you haven't, too bad. And an example of that is in the 1950s, after the Second World War, in the UK, the National Health Service was started. That was an incredible achievement. I mean, that was so impactful that people who had no money could now access health services for critical things like TB screening. They didn't have to pay antenatal care and deliveries, and it was open to everybody, free at the point of entry. That's incredible. In the TB program, to get people to come for TB screening, they were actually having lotteries and giving away cars. And, you know, if you come for screening, you might win this car. This was really about bringing this opportunity to the biggest amount of people you could. We're now, sadly, 75 years later, in a situation where healthcare imaging has become a commercial, a commodity, based on no evidence or little evidence, based on exploitation of people's fear for their health. And you can have an annual MRI just to make sure you're fine. That is really not evidence-based, good, you know, diagnostic scanning in order to solve a diagnostic clinical problem. That is using medical imaging as a way of making a business. And you can see that if you pay £2,345, then you get a discount on your prostate MRI scan, which you didn't need in the first place. Individual beliefs are important, because my individual belief, and that's just mine, is that to me, that is not a good standard of care. But that's just my belief. So in this way, I'm showing you how standards are formed and influenced by so many different elements. So when we now focus in on the radiology guidelines, and you may hear from others more about the actual detail of suggestions of how you can do things. I'm not doing that. There are the universal ones we talked about. So there's Image Wisely, you know, about being good with radiation safety. The International Atomic Energy Agency has lots of material and does work around, you know, making sure your installations are safe, that your X-ray rooms have the right protection. That's all universal. Data protection and image sharing is universal. We have to do that safely and responsibly wherever we are. But when it comes to context-dependent guidelines, so these to me are not global. We have the ACR appropriateness criteria from America, which is about, like I say, if a patient presents with a certain problem, what's the best test to do? The UK has the National Institute of Clinical Excellence, which gives guidance at a sort of more holistic level. So it doesn't just look at imaging, it looks at everything, all the costs involved, also the downstream costs in doing something. And I have an example so that I can explain that. But basically, they come out with advice and say, for this particular situation, spinal X-ray is not indicated. It doesn't achieve what you want to do in the UK population. That's super important to remember. And funding is aligned, so government funding is aligned with what NICE recommends. So that is a way of controlling where the funds go in a way that it is most effectively and fairly distributed. The Diagnostic Imaging Pathways is an online tool that it's interesting looking at the website. I couldn't actually work out who's created them or whether it's a private company or organization. And they make them freely available for everybody. On the website, it says, you know, we believe in free and equitable care for all. And these guidelines are freely available, especially for emerging economies and countries, whatever that means, emerging. But you're all here and you always have been. But what they mean is obviously, you know, countries that are going to now start to invest in developing imaging services. But when you then look at the detail of the guidelines, say a patient is diagnosed with colon or presents with colon cancer symptoms, a colonoscopy or a CT colonography is recommended to make the diagnosis. And to stage it, then they say CT chest, abdo, pelvis. Now, if you work in a well-funded or reasonably funded tertiary center, you would probably say, yeah, that is what it is. But that is only for the people in that particular situation. For the vast majority of people on this continent, they're but at the moment, not going to be able to access CT. So what do we do with those? So in the Asian region, what they've done is they've developed resource stratified guidelines. And I think that really is the way forward. I think that is such a great way of thinking about it. So what they do is they did a panel consensus, clinicians, imagers, everybody, and they divided up basic level, limited level, and then there is also sort of tertiary level. If the patient is at the basic level and cannot progress through the system, it's all about prevention, working towards getting infrastructure in place to improve, meanwhile having palliative services available. If you're at the limited level, so there may be a hospital where surgery can be done, where ultrasound and X-ray are available, you should still use your colonoscopy if you can to make the diagnosis, but they recommend abdominal ultrasound and chest radiography for staging. That may not be as accurate as that CT, but that difference in accuracy is what you need to accept in order to be able to stage this patient at all. They cannot access CT. So this is a recommended sort of next best step, as it were. Sometimes people get it completely mixed up. And I think that's because we are now having this, you know, people look at guidelines from wealthy systems, but they're dealing with patients who are maybe in, you know, like in TB endemic areas, and trying to work it all out, you can end up with some very sort of mixed up thinking. I'm interested in tuberculosis and imaging, so I thought, oh, good, there's a review article. And as I started reading through it, I thought, this is all about PET-CT. But they were presenting it as a sort of an overview of imaging in extrapulmonary TB. But actually, it was all about PET-CT. And there was no mention of even just box standard X-ray. There was no mention of ultrasound looking for lymph nodes and splenic abscesses and all the stuff that you can do for extrapulmonary TB at all in the paper. And somewhere along the way, it said whole body PET-CT may shorten the time period involved in assessing disease burden, and it may play an important role in decision-making regarding the duration of therapy, especially in developing countries. This makes no sense. Yes, PET-CT has been great in understanding TB better as a disease, how it waxes and wanes, and for research purposes, but for clinical practice, this makes no sense at all. So looking at developing local solutions, and I need to get on with it a bit, they need to be these are my opinions of things to consider: patient-centered, accessible, and fair. Informed by disease epidemiology at the site of implementation, align with health service capacity and priority, and that's workforce, and I'm sure you'll hear more about this today. Multidisciplinary, we need to work with our colleagues within radiology and in medical imaging, and with our clinical colleagues and policymakers and everybody. And I would really strongly advocate a way of thinking of balancing adaptation of what's out there. There's a lot of guidelines from the global north or wealthy countries can be adapted and are very useful. We need to innovate, and AI development is one example, but we also need to remember to preserve and not throw all the babies away with the bathwater, because there's some really good things happening in radiology in Africa that we have completely walked away from in the wealthier settings, and we've lost something with that. So access is about, just very briefly, thinking about, is a service available to the patient? Can the patient afford it? Can they access it? Can they get there? Can they understand the people, speak to people? Is the care adequate? Are they getting quality care when they do go there? And patients need to be part of that. They need to inform whether they are getting what they need. And is it appropriate? And appropriate takes into account the needs of the whole population. And sadly, the word all fell off the slide, but the healthcare that's provided meets the needs of all groups in the population. Then you have a truly accessible system. So some examples now. This is from Malawi, where a colleague of mine looked at patients' pathway to diagnosis for cancer and palliative care. And what she noticed, I'm just needing to get rid of my thing here, sorry, hide thumbnails, yeah. She looked at the mean time of onset from symptom to diagnosis. That's what we're here for, to make the diagnosis. Half and half, about 150 patients, and they all took roughly 10 months between symptoms and diagnosis. And if you look at the number of times they had to visit a health clinic on the y-axis in order to get that diagnosis, the majority of them had to do over 10 visits, before they actually got a diagnosis. That delays treatment. It means they don't get into palliative care on time. They spend lots of money going in and out of these clinics, creates anxiety and poor quality end of life. If there was good diagnostics, then they would be diagnosed much earlier in the pathway. So now I'm going to tell you some patient stories just to illustrate what I've just said. These are true stories, but I've completely de-identified where they're from. So this is just to illustrate the example. But they're not unusual. A 40-year-old female who presents with a long history of PV bleeding and a palpable pelvic mass. She's poor and she has no health insurance. An ultrasound was ultimately, when she got to the point where she could have an ultrasound. The pelvic mass was confirmed with ultrasound. Therefore, she was then referred to the gynecological services. You worry about gynecological cancer, and they recommended she have a CT scan for staging. Because she has no money, she absconded from the system. She just disappeared. There's no way she could have a CT scan. And she was therefore completely lost to any kind of further care. She couldn't, I mean, most importantly, palliative care and support. If you now think what could have happened if the person who did the ultrasound had been trained to understand about staging cancers, then they could have done that staging there and then. And in very many, because patients here present so late, very often that works really well. It's very sad for the patient, but you can do a lot of that with ultrasound. And the sonographer would have seen, sonographer being radiologist, sonographer, clinician, doesn't matter who's actually doing that scan. This is about the principle. If you know that pelvic cancers can obstruct the kidneys, and that if you see bilaterally obstructed kidneys in a large mass in the pelvis, which is most likely a cervical cancer, if it's deep in the pelvis, then you know that bilateral hydronephrosis is late stage cancer. If you then are able to see para-aortic lymph nodes, because you've learned, then you know that this patient is a late stage presentation, and you can then refer her to palliation and completely skip that loop of doing the CT staging where you lost her to the system. And this is not a random, it happens every now and then event. We know that cervical cancer is the biggest cause of cancer in women in West Africa. And this is a scenario that when I was in working here, I saw sadly way too often. So it is worth adapting our ultrasound protocols and the way we do it, because it's a prevalent problem and it will really impact on how patients experience their pathway. Here's another example of a 65-year-old man who presents with urinary retention. He has few savings, but there is no access to specialist surgical services in the area he lives in the hospital that he's in the sense that if he needed complex prostate or bladder surgery, that would not be available. So what happened? On ultrasound, a large prostate bladder mass was prostate versus bladder mass. Big mass, you're not always sure if it's from the prostate or the bladder, with bilateral hydronephrosis. So then, given that major surgery was not accessible to him, he had bilateral hydronephrosis. There was basic interventional services available, ultrasound-guided nephrostomies were performed on him in both kidneys. And he basically spent the rest of his 6 weeks of life going in and out of hospital with the nephrostomy drains falling out, getting infected, needing a new one. He spent the last 3 weeks of his life, the last period of his life, messing about with these nephrostomies. What could have happened if thoughtful counselling of his, the stage of his disease and his prognosis, and the reason that may have been the better pathway is because we know that in patients with advanced malignancy, they have reduced survival duration and spend a significant amount of time in hospital if you treat them with bilateral nephrostomies. That information comes from a paper from the Global North where, this is also not the right treatment. It's not because there is no resource, no funding, but it's because it's the wrong thing to do wherever you are in the world. Or not wrong, but you need to discuss it with the patient, obviously, but I would argue it makes their life worse, the survival period shorter, and you've not had a fair conversation maybe with them where this is going. So this is how evidence from a different part of the world can feed into your decision making. Then when you do guidelines, it has to be informed by disease epidemiology. And this is my example about using NICE guidance. If a 26-year-old female presents with 6 months of lower back pain and has no red flags like neurological deficits, NICE guidance says in the UK, there is no impact to doing imaging, none. No x-rays, no MRI, nothing. Physiotherapy, pain relief, but imaging does not contribute to a better outcome. If you just take that guidance and start implementing it here, and your hospital is in an area where TB is prevalent, and you follow this guideline, you will miss this. If you had stuck with the old-fashioned way of preserving the way of taking lumbar spine x-rays in a patient with those symptoms in your setting, you would have missed this lesion in this vertebral body. Here you can see there's a lesion here. And TB of the spine is prevalent, and if you catch it at this point, she doesn't yet have her gibbous. If you hadn't done the x-ray, she may have come back 6 months later, the vertebral collapsed, the spine, the cord compressed, and she's then ended up with a paralysis. So be careful which guidelines you take and which ones you leave, and where you stick with what you know already. So then levels of care. This is a really helpful paper. I find it really useful to think about which tools in your box do you apply at which level. So you can see the majority of patients, high volume, low costs, point of care ultrasound or non-radiologist ultrasound. And as you go up through the tiers, you end up with all the more specialized investigations, smaller numbers of patients, much higher resource need, specialist resource need, radiologist, medical physicist, everything. But you can see how the reach, the number of patients that can access that dramatically reduces. So we can think about what we're doing at that high level, but we must also think about the lower level, and also how only those patients from the lower levels will find their way into the appropriate endpoint in the higher levels. When we develop local solutions, I think multidisciplinarity is absolutely key. We have to do this with our referring clinicians. We also have to educate them. They may have gone somewhere where they think every patient with pancreatic cancer will need CT staging because that's what they did where that person trained. Explain to them that if you can see the pancreatic cancer and the liver mets and the lung mets on X-ray, what are you going to achieve from doing that CT scan? So it's a joint effort. I'm a very strong proponent, I said already, does that? Oh, okay. And our point of care ultrasound program is a perfect example of that. We have clinicians, we have sonographers, we have radiologists, and together we are trying to develop and strengthen ultrasound provision for patients. And I think we need to think about new roles, innovate. Can we think of even new roles that don't exist at the moment? Clinical officers who do a bit of diagnostics and a bit of pathology so that they can do the two together. Role extensions. I think all these things are things to explore. For time's sake, I'm going to skip this example. This one I'm fond of because this is about preserving. This is a workhorse of diagnostics when it comes to radiology. Everywhere you go, more, basic chest X-rays are very prevalent. But unfortunately, it's quite complicated and tough to be able to really interpret them well. And I think there's a lot of mileage potentially in, as a community, really helping people get better at doing this rather than reverting to CT scans or always ending up with right upper lobe pneumonia diagnosis in a case like this. HIV patient, young woman, presents with neurological decline, and this is her chest X-ray. And if we know that she has HIV and she's neurologically compromised, when we see a big dense consolidation in the right upper lobe, a rounded consolidation, we should carefully look whether there are others. And you can see there is a second consolidation behind the heart, also rounded. Then if you know your stuff when it comes to chest X-rays, in this history with two big dense consolidation, rounded lesions, cryptococcal pneumonia is the very most likely diagnosis. So really upping the ante, the treatment is different. So really upping the ante on developing people's chest X-ray reading skills can really also reduce cost and widen access. Few practical examples from my experience, just for the fun of it. I arrived, I had to write everything by hand on the back of the request forms. So I introduced copybooks with templates to make it easier for me. I even worked with the secretary to get her to start typing recorded reports, and she loved it. And between us, we really managed to increase the throughput. So think a bit imaginatively about how you can improve workflow with some simple methods. And again, for time's sake, I will skip. So what we do in Worldwide Radiology is we try to put in practice what I've just talked about. So we work with clinician ultrasound training and context-relevant bespoke protocols. So exactly that example, if you find a pelvic mass, look at the kidneys, look for lymph nodes, take it further than just the mass in the pelvis. We have sonographers who then learn about the clinical side of things. We're really hoping to bring everybody together around this program. Work across the board with policymakers. In Malawi, we have a collaboration with a university, with a research institute, postgraduate training program, and with ministry. So we did a workshop bringing together all the stakeholders. How can we best take forward imaging in Malawi? And we do take part in research projects. This is an example of AI application to detect likelihood of TB in a chest X-ray. That is now pretty well validated for adults, but validation in children is not yet complete. So we are supporting a program where we are developing a pediatric X-ray library set that developers can use to also improve tools when it comes to using them in children. So now I come to the end and my suggestions for future directions. I think it's really important, as you can tell, this is what I believe in, that we align the development of standards across all levels of care, not just focus on what we're doing in our specialist radiology departments, but think about all the stuff that comes before that. Maybe review what I would like to call imported standards rather than global standards that you have to aspire to. Some of those are really valuable, as we have seen, and you can adapt them. But just take another look and think, what we're doing in our practice, is that actually an imported way of doing it, or is that actually the best way of doing it for our patients? I think there's lots of exciting work to be done around expanding local evidence base, doing studies of, what is the best tool in your patients. And I would say, rather than global standards, think about African standards. And because Africa is so huge, the same almost applies to African standards. You'll have national standards, regional standards, local hospital standards, and they all have to work together ideally. And I'm incredibly grateful that I've had the career I had or have, that I've met wonderful people on both sides of the coin. And with Worldwide Radiology, I'm really excited to continue partnerships and working with all the wonderful healthcare providers on this continent towards these future goals, sitting side by side. Thank you very much.
Thank you so much, Dr. Liz, for that insightful presentation. Guys, let's give her our hand claps. Let's engage our virtual hand claps. Thank you so much. It has been a very wonderful presentation to listen to. And it's truly amazing how much radiology has evolved in just the past 2 decades. And some of us are even older than that. And we can also see that much of this advancement, as you highlighted, has been driven by necessity and pressing needs within different contexts. So if necessity really is the mother of innovation, as they say, then Africa should be a very fertile ground for developing local solutions that are both contextual and communally relevant. And I couldn't agree with you more on the point that while maintaining universal standards is essential, the global standards we adapt don't always have to mirror those of the global north, but rather should reflect our realities, our resources, and our goals as a continent, and all the while ensuring we balance adaptation, innovation, and also preservation of the great things happening in radiology in Africa. Thank you so much, Dr. Liz. So we'll be opening, the floor is open for questions, and we'll really love to hear your voice. So please raise your hands and we'll give you the opportunity to ask your questions. Nonetheless, you can also type your questions in the chat box and we'll read it out for you, but we prefer to hear from you. So I'll start with a question in the chat box. Okay, so this is from Dr. Toby, and he says, so many times we have not so upgraded machines in Africa, and I can say we still make diagnosis with them. How can we support patient care if a condition that needs a cross-sectional imaging modality to nail the diagnosis is not available? Dr. Liz, I don't know if you would like to throw some,
Yeah.
thoughts on that.
Yeah, that is the core question, huh? That is at the core of all of this, that if your equipment is not available and or available or not working because we know there are massive infrastructure issues with maintenance, and you haven't got the alternatives, like I said, of having somebody who can do ultrasound, if it really requires MRI to look at a spinal cord lesion, for example, and there's no other, then I'm afraid the answer is that you can't do it. I mean, that is exactly the gap, isn't it? That huge expanse with very few services and the gap to be addressed. And when you address it, I think that's where you have the opportunity to then think about, okay, so what else could we do, and how do we get to the point that we can not disappoint patients like that?
Yeah, thank you so much, Dr. Liz. So we have another question from Dr. Al-Hassan, and that's a long one. So just so we can test Dr. Kayende's microphone to make sure it's working now, I'll just call Dr. Kayende to help us read this question.
Hello, can you hear me?
Yes, we can, Dr. Kayende. Can go
All
ahead.
right. So, Dr. Al asks, is there any suggestion as to roping our clinical and surgical colleagues into some sort of dialogue towards proper imaging of patients? He says that they've seen some questionable requests at their centers, and it's either there's no proper channel for that patient's care, or the first imaging tests they came across aren't updated on the current standards of imaging. So I think what is basically asking, is there any way to update or to probably work with clinicians from other subspecialty in maintaining like quality imaging standards, if that makes sense?
Yes. It makes complete sense, and I wish you luck. Or strength, maybe. This is something I think in radiology, and I really think our colleagues in the North, when it all went crazy, when I trained, that's exactly what happened, and we were the gatekeepers. And we would explain why something was the right thing or the wrong thing, and we would have to have our knowledge and argument. We were the gatekeepers. And it has really changed over time into the clinician, not all of them, but feeling that we are like a service that you buy. I decide this patient needs X, therefore you go and get it. And I think we absolutely should take that initiative back. And that is through education, but it is also through really being strong and being, if you have a guideline, also, and guidelines mean nothing without enforcement. So then your head of department would have to back you. The head of hospital will have to back you. That, you will then, I mean, it needs doing, absolutely, and it needs to be done collaboratively, ideally by X-ray meetings, by education, journal clubs, getting them involved in the thinking. But I have had so many, as I've gone through my career, it has changed from this patient, please can we have a barium examination of this patient, to I am ordering you to do X, Y, or Z. But it needs pushing back and changing. I totally agree.
Mm, mm. Thank you so much. Thank you so much, Dr. Liz. I think because of time, those are the questions that we can take for now. And once again, thank you for such an insightful presentation. I think it leaves a lot for us to reflect on. And thank you so much for being here with us, Dr. Liz.